Hello everyone and welcome to another Part 1 question set. My name is Dr. Christopher Lewis. Let's get going. A female infant is brought to the clinic for evaluation of her genitalia. On exam, clitoromegaly and labial fusion is noted. Lab studies reveal elevated 17-hydroxyprogesterone levels. What is the most common form of adrenal hyperplasia? And then which hormone levels are altered as a result of this enzyme deficiency? And what are the clinical manifestations of this enzyme deficiency? So the most common form of congenital adrenal hyperplasia is 21-hydroxylase deficiency. And then when we're talking about which hormone levels are altered as a result of this, you have decreased aldosterone and decreased cortisol, but then you're also going to get increased sex hormones. And then what are the clinical manifestations of this? Well, 21-hydroxylase deficiency manifests with hypotension, volume depletion, and hyperkalemia because of the low aldosterone. You're also going to have masculinization effects in females because of that increase in androgens. Next question, what is the mechanism of action of the following antiemetics? So the first one is scopolamine. So scopolamine is an anticholinergic drug. It's an antagonist of the M1 muscarinic receptors. Now we usually use it to prevent motion sickness and to prevent seasickness. It's usually a little transdermal patch that you put behind the ear on the skin. Next we have promethazine. So promethazine is an antagonist of both the histamine receptors and also the D2 dopamine receptors. Now chemically it's a phenothiazine like chlorpromazine and other antipsychotics, and it might help you to remember that it blocks those D2 receptors. Next we have prochlorperazine, also a phenothiazine, and it's also going to block those D2 receptors. It's an older drug that isn't used that much anymore. Metoclopramide is also a D2 receptor antagonist. It's often used as a prokinetic agent to kind of speed up that GI tract, increase the transit time. It's used in patients with diabetic gastroparesis. And the last one is ondansetron, which is actually quite different. This is a serotonin receptor antagonist, specifically it's the 5-HT3 receptors. Now, it was originally used to treat severe nausea, like in patients on chemotherapy or post-op nausea. Now we use it for all types of nausea. Next question. A 25-year-old man complains of a scrotal mass and pain made worse by coughing or sneezing. A scrotal exam reveals a palpable scrotal protrusion with the Valsalva maneuver. What type of hernia is this patient experiencing? What type of hernia protrudes through Hesselbach's triangle, and what structures form Hesselbach's triangle? So this is a classic presentation of an inguinal hernia, and the important thing to remember here is that you actually can't distinguish on clinical exam whether something is direct or indirect. Now, what type of hernia protrudes through the Hesselbach's triangle? Remember, the direct inguinal hernia protrudes through Hesselbach's triangle. It begins its protrusion medial to the inferior epigastric vessels, while the indirect hernia begins its protrusion lateral to the inferior epigastric vessels. And then what forms that triangle? Remember, it's the inferior epigastric artery, the lateral border of the rectus abdominis muscle, and the inguinal ligament. Next question, how does a decrease in renal artery pressure cause an increase in blood pressure? So when renal artery pressure drops, the kidneys kind of panic. The juxtaglomerular cells start secreting renin, and they stimulate the renin-angiotensin aldosterone system, and that's to raise the blood pressure. Let's go into detail on this. So here are the basics. So first you have renin is going to cleave angiotensinogen to form angiotensin 1. And then angiotensin converting enzyme converts that AT1 to AT2, angiotensin 2. Now AT2 has two functions. It's a potent vasoconstrictor, so it will raise blood pressure by itself. And also AT2 also stimulates the adrenal glands to secrete aldosterone, which causes the kidneys to retain sodium and water. And when you retain sodium and water, you increase the intravascular volume and again, raise the blood pressure. Next question. What are the three endogenous androgens in order from the most potent to the least potent? So DHT is the most potent, then testosterone, then androstenedione. So it goes DHT, testosterone to androstenedione. That's going to be your weakest one at the end. Now remember that the last two hormones can be converted to estrogen by the peripheral fat cells. Important to remember that. Next question. What is Rendu-Osler-Weber syndrome? So this is also known as Osler-Weber-Rendu syndrome, or hereditary hemorrhagic telangiectasia. So it's an autosomal dominant disorder where you have telangiectasias in the skin and mucous membranes, and possibly in organs like the lung, the brain, and even the liver. And you can have little aneurysms in these telangiectasias as well. Now, these can cause bleeding, especially nosebleeds and GI bleeds. And because of all these telangiectasias and arterial venous malformations, the heart has to work a lot harder, and ultimately this results in high output heart failure. Next, what is the fibrous band attached to the testis and scrotum that aids in normal testicular descent? And then what is this structure called in females? So this is called the gubernaculum, one of my favorite words. Now the female equivalent is the ovarian ligament and the round ligament of the uterus. Next question, what are the effects of NSAIDs inhibition on PGE2? And then what role do prostaglandins and angiotensin II play on the renal arteriole? So first we're talking about NSAIDs on our prostaglandins. So what does PGE2 do? Well, PGE2 is a bronchodilator and a vasodilator. So it is decreasing the smooth muscle tone in these tissues. So the bronchioles dilate and the arterioles are dilating. So if you give NSAIDs, they will inhibit cyclooxygenase and actually inhibit the production of those prostaglandins. So you're going to get increased vascular tone, increased bronchial tone, and you'll have vasoconstriction and bronchoconstriction. Now, what role do prostaglandins and angiotensin II play on the renal arterioles? Well, we just said that prostaglandins are vasodilators. So in the kidney, they're going to dilate the afferent arterioles, and that is going to increase GFR because more blood is going into the glomerulus. Now, what does angiotensin II do? Well, it tenses angios, right? So it is a vasoconstrictor, so one of the most important vasoconstrictors in our body. So angiotensin II is actually going to constrict the efferent arteriole of the glomerulus, and that's going to increase GFR and filtration fraction as well, because the blood that's coming into the glomerulus has a harder time getting out through those narrowed efferents, so that GFR rises because you're just shunting in that other direction. Next question. What is the difference between a case control study, a cohort study, and a clinical trial? Which studies use odds, ratios, and which use relative risks? So a case control study is a retrospective study where you study a group of people with a disease and then you compare them to a group of people without a disease. So maybe you're looking at people with squamous cell carcinoma of the esophagus and you're trying to find out if smoking causes that squamous cell cancer. So you ask this group of 1,000 patients with esophageal cancer if they ever smoked and how much and when they quit and so on. And then you ask 1,000 people without esophageal cancer if they've ever smoked. So it is a retrospective, and you're going to be able to calculate the odds ratio on that one. Now, a cohort study is where instead of starting with the disease and working backwards, you generally start with the proposed risk factor, and then you see whether or not they develop the disease. So you look at a group of smokers and then see how many of them develop squamous cell esophageal cancer. And then you follow a group of non-smokers and see how many of those patients develop cancer. So cohort studies are usually prospective, but they can be retrospective. And this is going to let you calculate the relative risk. Now, if you smoke, what is the risk of developing esophageal cancer compared to if you never smoked? And then a clinical trial is a prospective experimental study comparing outcomes from two different treatments or comparing a treatment to placebo. So this doesn't use a relative risk or odds ratio. Next, T cells are found in the paracortex of the lymph nodes between the follicles and the medulla. Which cytokines are secreted by the two different types of helper T cells, Th1 and Th2? Well, T helper 1 cells make IL-2 and interferon gamma. And then T helper 2 cells make IL-4, IL-6, IL-10, and IL-13. All right, that brings us to the end of our question set. Hope you learned something. See you next time.